Everyone, we're going to get started in just one more minute here. Thanks everyone for joining. I know it's summertime. It's hard to get everyone's schedules to align, so happy everyone could join. I'm going to go ahead and get started. I think we'll have a few people joining us late, but we'll go ahead and get started because our time is limited. We have a lot to cover. So thanks everyone for joining us. This is the second in our series um, regarding pediatric oncofertility um, around clinical conundrums. So I'm really excited to host this webinar because these are questions that I struggle with every day. I'm Lexa Walsh. I'm here in Phoenix Children's Hospital. I also want to shout out to my amazing clinical coordinator, Kathy Hinkle, who's on. And I want to introduce our panelists. So first we have Dr. Sue, who is a professor. I'm just going to do a few minutes of introduction because our panelists are amazing. Dr. Sue is a professor of OBGYN and reproductive science in the Division of Reproductive Endocrinology and Infertility at the University of California, San Diego. We're all jealous of her location right about now. She's a physician scientist dedicated to improving reproductive health of young people with cancer. Clinically, Dr. Sue directs the Oncofertility program at UC San Diego, which provides cutting-edge, evidence-based fertility preservation care. Partnering with cancer survivors, clinicians, and researchers, Dr. Sue and her team conduct research focused on estimating reproductive risks after cancer, delivery of evidence-based practices, improving equity in reproductive healthcare delivery. Welcome, Dr. Sue. We also have Dr. Emily Hurley, who is an assistant professor of clinical obstetrics and gynecology at the University of Cincinnati College of Medicine and a reproductive endocrinologist at UC Health. She is double boarded in the college, in American Board of OBGYN and in reproductive endocrinology and infertility. And she served as a fellowship director of REI and the director of Oncofertility at UC. Clinical interests include fertility preservation, primary ovarian insufficiency, and recurrent pregnancy loss. Her research has focused on ovarian stimulation outcomes and reproductive counseling in young women. And then we have Dr. Shane Lipskind as well, who's a friend of mine here in Phoenix and a longtime collaborator. He is the medical director and director of fertility preservation at CCRM Fertility in Arizona, in Scottsdale. He also is a clinical assistant professor at the University of Arizona College of Medicine. He did his residency at Northwestern and his fellowship in reproductive endocrinology at Harvard. And he's a top doctor in Phoenix. So thank you all for joining us today. This is the first question that we're going to be discussing. So this was a question on our Oncofertility Consortium member survey. So there were 51 respondents to the survey. And the question generated quite a bit of diversity in responses. So the question was, a postpubertal female patient has already received gonadotoxic chemotherapy and now wishes to pursue fertility preservation 1 year after completion of therapy. AMH testing shows a value of 0.4 nanograms per milliliter. Would you offer fertility preservation procedures such as oocyte or embryo cryopreservation and choose all that apply? So a few respondents said they would not offer either oocyte or embryo cryopreservation. 2 respondents said the AMH was too low. 7 respondents said that they would recommend rechecking the AMH and seeing if it improved. 12 respondents said if on OCPs, which might alter your AMH, and you can't use menstruation, FSH, LH. And then 17 said if they're having regular menstruation, and the majority of patients at 20 of respondents at 21 said yes if LH and FSH were within normal limits. So the majority of respondents would offer those procedures conditionally on FSH, LH normalization, or ongoing menstruation, and AMH alone is not the sole determinant of eligibility. I kind of wanted to make it a little bit more specific for our discussion today. So the case we're going to be discussing is a 15-year-old female who had localized Ewing sarcoma, received the standard chemotherapy for localized Ewings, including VDC and IE. She's now 1 year after therapy. She received very high doses of alkylators and is considered at high risk for future infertility. And now she's interested in pursuing fertility preservation. So, Dr. Sue, let me start with that with you. With an AMH of 0.4 in a 15-year-old, that number raises concern for us, but we know that AMH is acutely suppressed during chemotherapy and can recover. How do you interpret the value and how would you counsel this patient?
Yeah, thanks for that question. I think that AMH one point in time is not, so there are two reasons for this AMH. One reason is because of this large alkylator exposure. The second reason is because she's just 15, and we know that AMH in childhood is super low and really rises, and there's a little bit of controversy whether we really hit peak somewhere between 15 to 25 for females. The second piece of data is that post-treatment, best that we know, AMH recovers over 18 to 24 months, and then assuming no other insult, stays pretty stable for some number of years. So I guess to the prior slides responses, I don't stem or not stem based on an AMH level. I think FSH is reasonable because if it's super high, you're not going to get a response using your gonadotropins. But my question is, it's pretty hard to put a 15-year-old through this. And so why wouldn't we want maybe I probably was one of the ones that answered the 6 to 12 months to see if you still see an increase, because if you continue to see recovery, you might have more yield in a given cycle. So those are my thoughts.
So moving to Dr. Hurley, I wanted to talk a little bit about the treatment side of the equation. Obviously, she's at high risk for development of infertility, and she is in the high risk category. I'm just curious from your perspective, day to day, does the dose of alkylator, how much does that impact your counseling of a patient and offering different fertility preservation methods?
Yeah, thank you for that question as well. I think when you use the Pediatric Initiative Network, when you do the risk assessment score and you look at the CED, it's nice because this will give you more information, especially with counseling the patient. You can look at their age, are they pre or post-pubertal, the dose, the CED, and say, okay, do you have a minimal increased risk? Is there an intermediate risk? Or are you very high risk? And like you mentioned, she's at this high risk. So when I was at the Oncofertility Consortium, the conference a few years ago, there was one presenter that said, there's no risk chemotherapy. And I thought, that kind of stuck with me. And it's something I share with patients. We can give you this risk assessment score, but probably any chemotherapy exposure is going to have some effect. But when we look at the alkylating agents with the cyclophosphamide and then the additive effects of the ifosfamide, we know that she's at very high risk for infertility in the future and undergoing menopause early. So I think it's a discussion, it's a useful tool where you can quantify their risk of ovarian failure and further counseling. I mean, I agree. I think there's still a possibility that her AMH increases and that she might have a better response in 6 to 12 months, but we don't know that for sure. And so I think counseling the patient based on this high risk that we may not get many eggs with each stimulation cycle. She may require multiple cycles to get the egg reserve or the number of eggs frozen that she desires. But I think having these conversations and having these tools can be really helpful.
We know that this amount of alkylators is going to shorten her window of fertility. but we don't know exactly when that's going to happen. So, Dr. Lipskind actually has discussed with me multiple times when I refer patients to him after their treatment. Your yield is going to be higher if the patient is older, right? Is that your general consensus up until a point?
Yeah,
But
so we know that the risk of the gonatotoxicity is actually the risk is higher when you're older because your primordial oocyte pool or primordial follicle pool is smaller. So the older you are, the higher risk of damage you have. Also, we know with follicular growth, those follicles are more susceptible to damage. So once you're postpubertal, you're ovulating, you're growing those follicles, they're going to be damaged more by the chemo. And there's also going to be a decreased production of inhibitors and thus more primordial follicles being pulled out and growing. So more exposed to that chemotherapy. So we can counsel the patients the older they are, the more risk of damage they have with regards to the gonadotoxic therapy.
Dr. Lipskin, how do you consider those two variables, age at diagnosis and treatment, and age at potential harvest when you're talking to patients?
I think some wonderful points were already made. I mean, first of all, younger age at the time of treatment, as we said, is somewhat protective, a little bit lower risk for complete loss of ovarian function, which is good to know. As far as age at retrieval, in general, I think Dr. Sue pointed out that there's going to be just more maturity in the reproductive axis as years go on. And so in the absence of any chemotherapy exposures, some of our younger age women are going to do a little bit better than the younger age adolescents. And so that's just something to think about. In general, though, like when considering this patient, she's kind of already survived, her ovaries have kind of already survived the initial insult, right? She doesn't sound like she's in ovarian failure or insufficiency. I would say failure at the moment. She's got, a detectable AMH. And I think I agree with the other panelists. I would say because we're out of the imminent danger period, as long as there's no relapse or other, new treatment coming her way, I think the most prudent thing in a situation like this would be to wait, watchful waiting, see if there's additional recovery of her AMH over the next 12 months. And then also she'll be closer to young adulthood a few years down the road. And so just kind of starting the conversations with the family about, hey, we do know you're likely looking at a shortened fertility window, counseling them about monitoring for menstrual cycle functions as sort of a vital sign of her reproductive axis, serially checking AMHs. Sometimes we see them hover in these low ranges just for years and years, without really ever taking a further dive. And so, she might be somebody who, as she reaches the end of high school or gets to 18 years of age, that might be a more appropriate time for her to consider doing some sort of proactive preservation. But I think right now I would just watchfully wait in this patient.
Can I throw something controversial out there and see what you all think? So we have our pin stratification. One of the other tools that I sometimes use or often use is the Childhood Cancer Survivor Study Acute Ovarian Failure and POI calculators. So there's no, in my mind, based on, sort of my read of the EPI data, that these doses are, will increase these adverse reproductive outcomes, but what's the absolute risk? So if I plug in her age, I guess I'm assuming she's white, and her cumulative dose, that risk of acute ovarian failure for her, that means having no more ovarian function within 5 years of her treatment, 6%. Her risk of having POI, at least based on the CCSS calculator, is also 6%. So so it's increased risk, but the absolute risk is relatively still small. How do you think about that?
Yeah, I think that's really reassuring. And I think sharing that data with the patient and her family is critical. I think So I agree. There's time to delay, but I think close monitoring, having these conversations. I mainly practice with postpubertal adults, but I think when I see these young patients, bringing them into the office, showing them what a transvaginal ultrasound probe looks like, explaining the process, because they still, even though it's only 6%, still may want to freeze their eggs. And so I think the more you talk to them, the more comfortable their family feels with the process. And, I think this will come up later in our talk today, but financial burden's real. And so, I've had some families set up accounts to, for their birthday every year to collect money to try to save money for these processes. So I think having the conversations and sharing all the data we can with the patient and just making sure they're well informed is critical.
Yeah, I agree. I think it sounds like it's overall reassuring for the near term, but that's still just 5 years out, and this young patient is 15. So I don't, at least not in my clinic, I don't see too many patients presenting to me, that young, trying to have children, and so we can anticipate just the way that the norms of society are these days, that she very well is going to encounter fertility difficulties in her future if she doesn't do something, or at least have the opportunity to consider oocyte cryopreservation in the future. So I completely agree with Dr. Hurley in terms of just introducing the idea early on, gauging the patient's own receptiveness toward doing something like that. And oftentimes I'm really surprised just how mature these survivors are. They've been through a lot medically already, and oftentimes we think of the challenges that come along with doing daily self-injections of medications and doing frequent blood draws, transvaginal ultrasound monitoring. But I think that the shots and the blood draws are a piece of cake for a lot of these kids. They've been through way worse. And so I kind of leave it open to the family and to the patient and kind of gauge that with them. But I do think that it's still really important to let them know that that future risk exists, even if the 5-year risk is overall very low.
I'm often surprised working with these patients that they are so determined to have children. Many of them, that is really what they're looking forward to. And is there an AMH, FSH, LH, and lack of menstruation where you would say, I'm not going to try to harvest oocytes?
From really old data now, I think that an FSH of over like 2025, right? Because it was still with the same international standard, that's not been demonstrated to get you to a baby. Also, because when we give high doses of gonadotropins in STEM, we're really getting to FSH. If you measure somebody's FSH level, we're getting to like 15 to 20. So if their FSH levels are like 20, 30, what's the likelihood that our drugs are going to do anything different to those follicles that are not responding?
Yeah, I recently had a patient that came to me at 39 with breast cancer and, had a very, very low AMH and elevated FSH. And I think that's a conversation. She did desire children in the future at 39, and she felt like this chance was being taken away from her. And so we did offer her an attempt with very extensive counseling that there's a very high risk of cancellation, that you won't respond to these meds, and just gave her realistic expectations of the cycle. And we actually did end up canceling her after multiple days of stimulation because she didn't respond at all. But I also think giving these patients the option when there is a chance, very small, but still a chance, just because this is their only small chance. And so I think, again, talking about the risk benefits and counseling the patient. But I don't have a specific cutoff. But I think, you have to be aware if those FSHs are above 20, the chances are extremely rare.
I just wanted to add one more complication to this case before we moved on to the second case. So let's assume that this patient with Ewing sarcoma needed radiation to their pelvis. Does that change your counseling to the patient? As we know, high doses of radiation can also compromise uterine stability during the pregnancy, or does that not play a role? Dr.
I
Hurley?
think, I think it's definitely something that could have a major effect. From an ovarian standpoint, if there is exposure of radiation to the ovary, that could be an additive risk factor to the gonatotoxicity. And you could consider ovarian transposition or ovarian tissue cryo. The transposition wouldn't be an option if there was any concern for metastatic disease to the ovary, which I think with Ewing's is pretty rare, but still possible. If with the uterus, we also know that it can affect and damage the uterus and making it, a high-risk pregnancy. And it all depends on radiation exposure, the dose, but I think even less than 5 gray can affect pregnancy outcomes. So depending on the dose, you may discuss the option of needing a gestational carrier in the future. And at that point, you would recommend completing the FDA testing at the time of the egg retrieval. Again, further having this conversation with the patients about the costs, the options moving forward, so that they're aware of the journey they have in the future.
What are your thoughts, Dr. Sue, about adding radiation to the mix?
Totally agree with Dr. Hurley.
Okay, I'm going to move on to our second case. Oh, Kari, do you want to read the questions in the chat?
Yes. So before we move on, just a couple things about this case. From Melanie Davies in the chat, one sort of question, how for the REIs, how are you layering on to these questions about potential relapse into decision-making about this? Because, for example, this patient is 1 year post-therapy, but there still is a very, possible chance that this patient could relapse. We also sometimes see these patients earlier in our sort of oncology fertility clinics, even 6 months off therapy, and maybe with still that same AMH that isn't great, would that push you more to sort of risk a lower AMH and go ahead with retrieval, or does that give you a different kind of pause?
Well, I would say this is part of the counseling when you meet with the patient and say, hey, listen, right now, we assume you're in remission and there's no imminent threat now, like we were talking about earlier, but if something changes, then I need to be like the first person you call so that we can certainly try to move forward the preservation before any additional insults to the ovaries or the reproductive system. And so, should that happen, should this exact patient relapse, she's a year or more out from finishing her initial chemotherapy, I would absolutely offer her an oocyte cryopreservation cycle at that point, or potentially ovarian tissue, depending on what the treatment plan is going to be.
One more question I would offer, not directly related to the relapse, but I think Dr. Hurley, you had brought up, the lower AMH, this potential of needing multiple stimulation cycles to get enough eggs to sort of have a reasonable chance at building the desired family number in the future. So again, back to that cost question, when you're talking about an AMH of 0.4 and the family is paying, $12,000 out of pocket, how are those sort of counseling decisions made of, would it be better to wait 6 more months to see if it's 0.6 to get a better yield, a year to see if it's 1.2, knowing that you're risking a window, but also a family or a patient may only have one shot or one chance to really pay for this cycle?
Yeah, that's a really good question. Here in Ohio, we're mandated for diagnostics, but not for treatment. I work very close with my financial team. Let's run, if this patient's on their parents' insurance, let's run their insurance. Let's see what's covered. Is anything covered? It's a tricky conversation to have, but are the parents switching jobs or getting a new job? Here's companies with really good fertility coverage. I think that's really hard because you're right. What if it does reoccur? When will that happen? So I think having these conversations is tricky. And that's why like the GoFundMe things, the things you can set up so that they are able to start saving for other cycles in the future. You start to develop these tricks to keep in your back pocket when people can't afford it. I know we work really closely with Cincinnati Children's. They get a lot of grant funding. We work with multiple Oncofertility grants. The university is actually sending a fund to the cancer network here. So I think, reaching out for all of our resources that we can to try to get the money and funding to let patients do multiple cycles, but picking the correct time, it's very hard. I don't have a good answer for that. And I think, people ask all the time, well, how many do I need to freeze? And we can talk about the calculators out there. But I always tell people too, you could freeze 1,000 eggs and I would never guarantee pregnancy, or 100, either way. We can never guarantee it, but the more you freeze, the better. And normally at 15, I won't bring up donor egg and donor embryo, but that is something that I try to bring in at least at some point. that there are options in the future if this doesn't work out. And I don't necessarily bring it up right away. You know, that's a tricky conversation to have, but I think that's an important one, so that there are many different ways to build a family and that the patients know options if this doesn't work out using their own eggs in the future.
I guess I would just add to that because this is a solid tumor, what is the likelihood that we don't have 2 weeks at the time of a relapse? Right.
Yeah,
So
very
that gives us some
unlikely.
room. Yeah. Very
Yeah.
unlikely that we don't have 2 weeks, right?
Mm-hmm.
Yeah.
Okay, so this leads us right into our next case, actually. So this was another question that had a variety of responses. So the question was, a post-pubertal patient has relapsed 6 months off therapy and is sent for fertility consult for potential tissue cryopreservation prior to starting a new therapy. Unfortunately, they did not have fertility preservation at the time of initial diagnosis, and they are already at high risk for future infertility via risk stratification. So what would you offer this patient? So this question was for both boys and girls. So testicular cryopreservation would be offered by 14 of the respondents, oocyte criteria for ovarian suppression in 14, ovarian tissue cryopreservation in 20, oocyte cryopreservation in 29, and sperm cryopreservation in 30, obviously. But 5 respondents said they would not offer. I think in this case, if patients already relapsed, your chances of making it through the therapy go down significantly. So that's another component of the conversation, I think. So in this case, I just switched this to a 16-year-old, so a little bit older, with rhabdomyosarcoma, did not receive fertility preservation, already received high-risk therapy. So, they missed the opportunity for fertility preservation at their initial therapy. And now they're going to be getting additional therapy. So is the conversation significantly different from our case number 1? Dr. Sue?
Sorry. So the question is whether this person, I think it's sooner than the other one, right? Because the other one was 12 months, so may have had more recovery. But I think if you think primordial follicle activation until it comes into the menstrual cycle is up to 6 months, then hopefully the follicles that we see, if they're there today, are theoretically would not have seen her upfront therapy in their development in terms of thinking out potential like DNA changes, mutations as a result of recent systemic treatment. The other thing is because she has known, very gonatotoxic treatment coming up. That's what makes her different from the first one. For us, the ovarian tissue cryopreservation criteria is over 50% risk of acute ovarian failure. And so what we demonstrated in the prior case was that absolute risk was 6%. And so that patient would not have met our criteria. And I think the reason for us, that decision for us, is because while we are glad to be available for ovarian tissue cryopreservation, the current protocol in the US through the Oncofertility Consortium, there have not been a whole bunch of transplants for us to feel super confident about the freeze-thaw process. And so if I know that someone's, acute ovarian failure risk is 6%, and I'm not sure the benefit of taking out a whole ovary for both obtaining ovarian function and fertility later, I don't think I would be offering her tissue freezing. I think it depends on what that overall absolute risk is.
Dr. Hurley, what are your thoughts on this case?
Yeah, I agree a lot with Dr. Sue. I think we don't have, unless I missed it, when her treatment will start. I think if there is more than 2 weeks and we can fit in a stimulation cycle, I would offer her egg freezing. It has been 6 months, so I agree, with the lower risk of egg damage, but I would still counsel this patient that there could be some effects to DNA damage and the oxidative stress to the egg quality that we won't know for sure. But, I think there's still a possibility that her eggs are of good quality and that I would still offer her egg freezing if we had time to do so.
is there an overall risk of overall survival rate at which you would not offer ovarian cryopreservation or oocyte harvest? I mean, that's something we struggle with all the time, where our oncologist may say, "Oh, don't even talk to this patient; they're not going to survive."
Yeah, I think that's a very difficult question, and I don't have a number. I don't know if I'd love to hear Dr. Sue's opinion about that. I've had one patient in the past where the oncologist said, I cannot allow this patient to take any time. She's starting chemo today. And that, and I agreed. I think that cancer was so advanced at that point. But I think, it's an important conversation to have and include oncology and the patient.
Dr. Lipskind, how do you interpret hormone levels when a patient just has newly relapsed? Are they going to be indicative of true ovarian function if that patient is, under their hormonal axis is under stress because of the relapse?
That's a good question. I don't think it's going to be necessarily all that predictive. I don't think you know what you're going to get in these cases until you start the stimulation and see what happens. And you usually can anticipate they'll need higher doses of drugs and longer courses of drugs than normal. So I do prepare the patients for that, whereas we normally expect maybe 9 to 12 days of stimulation. Some of these will go, 20 plus days, but they may respond and you can get usable eggs. And so, I think I agree, and I'm actually very, very pleased to hear the other panelists say that they would offer, egg freezing, because I think that we kind of all get scared into this idea of, oh, we've just had chemo, it's been less than a year, and there's going to be DNA damage, and there might be, but when it's a very, very, very high risk of failure, then there's no other option apart from telling your patient, hey, you're going to lose all of your ovarian function, all of your eggs, and you're going to need to use donor eggs. I think it's very reasonable to still allow them to try to pursue the tissue freezing. And so I agree with the other doctors that I would. And I think it's also, a good case to do maybe a combination of both egg freezing and ovarian tissue cryo because of that very high risk for failure. And so, honestly, I would talk to them about both and very seriously consider doing both. So.
Can I ask a question?
You,
I think this is where we really could benefit from the oncology fertility team, because I think that if oncology teams could be super clear about whether this next treatment is for curative intent or for palliation, for me, I think if it's for palliation, I wouldn't proceed. Right, because I think we would be potentially incurring more risk than benefit. But if you all think that this is for curative intent, I mean, what do you think about that, Alexa? Like, do you feel like curative intent really is curative intent?
well, in pediatrics, unfortunately, I think we try for a cure even when it's not very realistic. So I don't, when I counsel patients, obviously I'm not the one doing the procedures, but when I counsel patients, I sort of have a number in my head of 20 or 30% survival, which I try to ascertain from the treating oncologist. Sometimes they're not very clear about that. But if it's less than that, I kind of tell the patients, I don't think I would recommend this in your case. This is going to be, you're going to have in ovarian tissue cryopreservation, you'll actually, be sore and have to delay chemotherapy a little bit. And with egg freezing, that would be even longer. So I think my counseling is different. I'm not sure how Kari and Lillian and other people approach it, but that's sort of my own cutoff.
I do think Alexa is very accurate that as pediatric oncologists, we are a very optimistic bunch, at least patient facing. I'd say we're probably not always that way privately or in the clinic rooms. But thinking about how, if you have a patient or family sitting in front of you and they're asking about, future infertility, it's really hard to give them an answer and say, well, you're not eligible because your chances of survival are so low. That is not how we typically communicate with families. So that's really challenging because certainly they expect that most of, at least our second line therapies are still with curative intent. And so I think just the vocabulary probably between pediatric oncology and REI is just very different how we sort of approach that. Um, but I think, different people sort of have different thresholds of what they think might be appropriate to hold on to that hope. A lot of ethicists would say that, we should not be withholding these types of procedures for patients because there is a possible chance that some of them survive. And we all have stories of that one patient that got, 6 lines of therapy and survived. So it's hard for us to be the gatekeepers and say yay or nay to a specific patient or not. And I think that's part of the real challenge that we have. I will tell you sort of anecdotally, personally, I'm sitting here talking to you guys from St. Jude, where we pay for fertility preservations for patients. But it gives me severe anxiety because when I have to think, with my business hat on of who should we be offering this to because we're paying this money, it's very different from a patient or family that says, I understand that my patient or my child may not survive long term, but if they do, I want this to be an option for them. I want them to build a family. And I think that's so important that I want to spend the money on that. That's a very different conversation than let's just throw money at, patients for procedures that maybe they're never going to be sort of using the fruits of. And I think Lillian turned on her camera to possibly add some commentary, but I think these are really challenging questions.
I think whenever we get not between a rock and a hard place, sort of defaulting to shared decision making and trying to present to the family all the sides of the question, all the options is important. I'm often surprised by decisions that people make that maybe I wouldn't make, both in terms of even sperm banking with high risk patients or sperm banking with low risk, those kind of things. I mean, it's a very personal decision. I would hate to be in Kari's position where I could pay for whoever. I mean, that's actually even, I agree, Kari, that's harder. But I often think we're trying to spare patients when we're sort of gatekeeping and telling, saying this is unlikely to be the right choice. But the older I get, the more I think, let me just try to bring all the information to them to help them make their decision. Sorry, that's long-winded, but.
Moving on a little bit, I wanted to, reproductive endocrinologists will be on the front lines when we ask you to reimplant the ovarian cryopreserved tissue. And so for this theoretical case, there is a risk that there's Ewing's in the ovary. I'm assuming, correct me if I'm wrong, but egg freezing, you should not have that risk of reintroducing the cancer into the patient's body. But with ovarian cryopreservation, our protocol here at Phoenix Children's, we do have put a piece of the ovarian tissue or the ovary is reviewed by pathology, so there will be a pathology report. But Shane, if I ask you to reimplant some frozen ovarian tissue from a patient, what is going to make you comfortable that we're not reimplanting tumor cells?
This is a huge question. I don't think there's going to be any absolute certainty that we're not implanting tumor cells, right? Because when you send a specimen to path, you're not sending all the tissue, and you're not sending the tissue that you're going to be putting back into the patient. So,
Right.
I don't think there's any way to be sure, but I think we kind of weigh that risk of what is the actual chance of ovarian metastases. And for most of these cancers, it's probably pretty low. And I think outside of, situations where we do have higher suspicions for metastases or even gross evidence of tumor seen at the time of surgery, I mean, I think you have to have that discussion with the patients and allow them to decide whether or not that is a risk that they're willing to take. And then obviously, as Irene mentioned, there's a lot more experience with the tissue freezing at this point than there is with the actual transplantations and using that tissue. And this is one of the things that, just have to raise that as a point in limitations of this technology right now. Yeah, it's great. There's a lot of promise. We might be able to restore both hormonal function and natural or assisted fertility opportunities for these patients that lose everything. But how well is it going to work? I think it's still difficult to answer outside of those few centers like in Belgium and abroad where they have a lot more experience than we have here in the United States. So I would counsel the risk of reintroduction of malignant cells. And I know some of the strategies that have been proposed to help mitigate that a little bit would be, orthotopic transplantation. So putting the tissue in a site remote from the pelvis, such as under the skin of the arm, where you might be able to monitor if something is growing there, more easily, or also allow for removal, for example, of that tissue after assisted reproductive technologies, IVF, have been performed. So, I mean, there's some options to try to mitigate that risk, even in the scenarios where, you have more concern. But it's just a large area of unknown. And I believe, although this concern has been talked about in theory for a long time now, I don't think there have ever been any reported cases of somebody having a relapse due to ovarian tissue transplantation. And so, I mean, that to us should also be, I think, fairly reassuring, but it's still early data and, very limited number of cases overall. And you don't want to be the first person that shows up, in the literature with a relapse. But that's one option. So orthotopic transplant, and then we're also really obviously very interested too in vitro maturation opportunities, right? So using this tissue to develop mature oocytes in the lab and use those for IVF and do IVF embryo transfer. That's the other way that we can sidestep that problem. But there's never going to be a situation where I would say there's, no risk. But I think overall that risk is probably going to be low in most cases.
In my personal practice, I often will choose ovarian cryopreservation over egg freezing, just because logistically it's easier for the patients and families. We offer that here at Phoenix Children's versus referring patients to an outside institution. And also, we have funding to help cover the cost for the family. Is that, Dr. Hurley, what do you think about that strategy? Would you still, I mean, obviously some patients aren't eligible for egg freezing. I know this is a question that comes up a lot, but would you still, I mean, given the concerns about reimplantation, would you still counsel patients to undergo egg freezing if that was an option for them?
Yeah, if they're able to, if they're post-pubertal and there's time, I think time's a big factor. I would recommend egg freezing, and you can always offer OCC as well. If there's time to do it all, but I think egg freezing is still, kind of gold standard and what I would recommend.
I think it really has always been. Okay.
Dr. Sue, what is your thought about that?
Yeah, I think that if that person's risk of acute ovarian failure is over 50%, then I would offer them both to do the egg freezing first, because I mean, I think my emphasis is really, this is what we do clinically. We quote the patient's numbers from Belgium, Israel, Australia, but also tell them that the very few cases of transplantation within the Oncofertility Consortium have not yet resulted in a live birth. So to remove tissue without knowing what the clinical outcome is, and there's some smart people who are going to have some thoughts about how can we use xenografting to try to predict outcomes. That's kind of the next frontier, but we don't have those data today. I also think, and be curious to the audience, I think the criteria with which we freeze these tissues in the States is probably a lot more restrictive because we have so much access to egg freezing. So for example, many of the tissues that we've frozen here have been like relapse patients versus sort of upfront. And maybe that patient selection is a reason why the transplantation in Europe has been kind of higher rates.
Well, yeah, one complicating factor I think that I feel is a fairly big issue in our field is that we do not have a standardized threshold for ovarian cryopreservation across the country. Institutions are able to choose their own thresholds. So it is quite variable, which patients are offered ovarian tissue. And it also varies a lot depending on where you're diagnosed. If you're in Cincinnati, you're in luck. If you're in North Dakota, you're not offered ovarian tissue cryopreservation. So I think that that's a big issue that needs to be addressed.
I'm curious, Irene, we've heard you say a couple of times that you really use this acute ovarian failure likelihood of at least 50% for ovarian tissue. Now, that is intertwined with the sort of the alkylating dose and radiation dose and the PAC risk schema that we have. But are you sort of using truly just that sort of AOF or POI sort of threshold, or are you including other things? And then I'm curious how that compares to the other REIs on the panel. Are we sort of all using the same criteria here, or are we going to have very different responses? Because my gestalt is that it is very different.
I think, Kari, what you're saying is that, sorry, what's different? What's different is the thresholds, or what's different is what people are using?
So, for example, I don't think everyone uses a risk of acute ovarian failure of at least 50% as their threshold. And that, like I said, it uses the calculator uses some similar data, obviously connected to where the PAC risk schema came from, but they're not equal or the same. And so many of us who are here because we're part of the Oncofertility Consortium, Pediatric and Adolescent Committee, the risk schema has been sort of gospel to many of us because we needed some place to start, and that's what we've used. And that's a little bit more tangible, I think, to many of us to use rather than talking about a potential risk of another outcome in the future. And acute ovarian failure, POI, those are sort of downstream from infertility. So they're, again, connected, but not the same outcome.
Yeah, I guess I would, so there are two things that weigh in the reason why we chose 50% was really, this is the criteria that we inherited from the University of Edinburgh. And so where they do a lot more sort of triaging and about sort of criteria for this, that's one. And two, again, I think that when the Oncofertility cryo media and protocol, slow freeze protocol was first developed, that is very akin to the same protocols that are happening, for example, in Belgium. But we have no clinical validation. And so if we have no clinical validation here, and truly and also the PIN, if I remember, these criteria are also based on clinical expertise, right? And it is significantly higher relative, but the absolute risks are not clearly delineated for, like, what is this the absolute risk for amenorrhea when we know most epi studies, the amenorrhea reverses, especially when you're young. So it's really hard for me to offer tissue freezing with no clinical validation of our protocol for someone whose absolute risk is like 10%.
What about in a prepubertal patient? Does that change for you?
No, I mean, I think that, well, and again, I guess we are here in the pediatric setting because I, of course, know that beyond the age of 21, we have no beautiful CCSS data and St. Jude's data. We don't have that. But in the ped setting, yeah, if you know that someone's risk of like losing all their eggs is 5%, are we going to offer tissue freezing?
We do. But there's no consensus. So
Correct.
I think that's a very good point.
And this is shared decision making, right? You've got like families who are like, I got to do something. I want to, I got to do this. Then this is shared decision making. I just really think the big like elephant in the room is a lack of clinical validation of what it is we're doing to the tissue right now to freeze it.
Well, this was a great discussion. I certainly learned a lot. I'd love to open it up for questions from the audience. you can either unmute yourself or put your questions in the chat. Do we have one, Kari, already? Question?
So Gina Sinmacher had, in reference to the second case, it was really more of a sort of OTC question asking about with such a low AMH, would higher caution be considered for OTC, given that the frozen tissue has fewer eggs than, a patient who had a more robust AMH. And I'm not, I think similar to what Dr. Sue is saying, with a lack of sort of outcomes data with ovarian tissue, I'm not sure that there's clear evidence one way or another whether OTC and using that tissue in the future would be more challenging.
Does anybody else have other questions? Any other questions?
I would just be curious to hear from Dr. Hurley and Dr. Lipskind of what their sort of OTC inclusion criteria might be.
Yeah, I think, what I explain to patients is OTC was considered experimental until recent, and so I think if I have time, and I see patients post-pubertal, so I don't see anyone, Cincinnati Children's takes care of our pubertal patients. But if I see someone and we have time to get eggs out, that would be my recommendation. I still think that's gold standard of care. So I would offer them egg freezing. Now there are some circumstances where that's not the case. So, if they have to start chemotherapy within 48 hours, and they're high risk for, severe high risk damage from gonadotoxic therapy, that would be a conversation I would bring up. I have a patient recently that's concerned for metastatic disease in the ovary. So we'll be taking, and is very young. And so, her oncologist is going to be taking out her ovaries. And so, those would not be she would not be a candidate for reimplantation. But, I think talking to her about, in the next 20 years, are we going to be able to perform in vitro maturation? And we don't know. There's a possibility that we're taking these out and storing them for many years with ever having the ability to produce an egg out of them. But I think having these conversations, because what if we can in 10 years? And then we're not reimplanting this ovary because we're not reintroducing cancer into her body, but we're giving her the chance, and she's able to maintain her uterus as of right now to possibly carry a pregnancy. So I think, I think it's a lot about patient counseling, but I still try to push egg freezing first and foremost if the patient's a candidate. And then if they're not, then we talk about the risk of gonadotoxicity, their age, and if we can offer OTC.
Yeah, I think that's really, really fair and aligns pretty well with my clinical practice too. I mean, I think when traditional egg or embryo cryopreservation is available, it's the more proven treatment option, and that's what we should be doing. For me, the scenarios where ovarian tissue cryopreservation come into play would be pre-pubertal patients, obviously. But luckily, we have PCH, and they have a good setup with Pittsburgh and their OTC program. So not needed for that too often. And then for the other patients that I see just come up in most frequently would be like acute leukemic patients. They're admitted and they go straight to the hospital. They're on the bone marrow transplant unit, and they're going to be starting their chemotherapy right away. I do wish that it was easier to catch these patients early and to have programs. We talked about the financial barriers and challenges. We've wanted to do tissue cryo for some of these patients, and unless you can manage to couple that surgery with a port placement or some other anesthesia, something else that they're doing surgically, it's a big challenge to be able to take care of that for them. But the pre-adolescents, the acute leukemics, those are the big ones. And then occasionally too, I'll have patients that have an indication for pelvic surgery, and they're high risk. I had a patient that was going to be getting pelvic radiation, and she was having ovarian transposition. And so we transposed one ovary and we removed the other and did tissue cryo for her. This is actually after egg freezing, so we were able to do both for her. So there's some situations where it's there because of opportunity, but others where there are significant roadblocks. And I think that we just need to continue to follow the data and see what outcomes look like when we are transplanting tissue, and obviously try to continue advocacy and push for coverage and other means to try to help patients access these different services when they really need them.
I think that is a great way to end the webinar, unless there's anybody else who has a last question or two. Really like to thank our panelists, Dr. Sue, Dr. Hurley, and Dr. Lipskind. Really appreciate your time and your insights into these cases. And I hope everyone can join us for our next webinar in the fall. We are going to be inviting some male fertility specialists to get their input on difficult cases.
Thank you so much.
Yeah, thanks everyone.
Thank you all.
Thanks, Alexa.
Thank you.
Thank you.